fellowship from the DBT Wellcome Trust India Alliance, which I began in 2017 and just completed a few months back formally. I would like to begin this talk by acknowledging a select list of Adivasi and tribal communities that we work with, and there's a reason why I use these words separately, Adivasi and tribal, which I will come to. But I would like to really acknowledge the trust, the faith, and the goodwill of the Soliga and Jainkuruba communities of Karnataka, the Katanayaka, Paniya, and Kurcha communities in northern Kerala, the Bega and Gond communities in Madhya Pradesh, and the Nishi communities in and around Pake Tiger Reserve in Arunachal, without whose trust, faith, and goodwill this kind of work that I will share would not have been possible. And I, of course, acknowledge several collaborators, mentors, and others who have been involved in shaping some of the themes that we will discuss today. So this is a product of collaborative, participatory, and team work, which I have the opportunity to share with all of you. I think one of the predominant narratives with respect to tribal health, if you look at the phrase or the discipline or the field, call it what, tribal health, the narrative is that of a gap. And I think this is something that is very important to keep in mind. Typically, evidence such as a study that was published in the Lancet in 2016 on the health of indigenous people across the world typically report a huge gap in the attainment of various human development indicators, but also healthcare access, healthcare utilization, and health status outcomes. Take infant mortality, take maternal mortality, all of them in indigenous populations seem to be substantially different from other communities in the region or the province or what. But I think one important thing we have to keep in mind is often in our work we tend to conflate or confuse the indicators attainment with people's own development status and their human development attainments. With respect to indigenous communities, this phrase "behind everyone, everywhere" was one of the phrases used by Anderson et al. In response to the largest data set that examines health inequalities of indigenous communities. Data from India was also part of this data set, and people like Dr. Abhay Bang and a few others from India also contributed and were co-authors on this study led by the Lovicha Institute in Australia. And the study clearly establishes the fact that various healthcare outcomes, healthcare indicators are poorer among indigenous people across the world. It's a common pattern. But what I was telling earlier about this idea of confusion and conflation, we must remember that we are talking of attainment of indicators where there is a deficit or gap. Often in the language we use, we are often characterizing communities as being backward, communities as being less developed, communities as being as having a deficit. And this is a very important distinction that, if we do not become conscious, has obvious implications also in the way we figure out interventions. So to a large extent in the fellowship, thanks to many of the collaborators from the Adivasi community whom we work with, we were also able to try and change our own mindsets with respect to how we characterize and communicate our findings about Adivasi and tribal communities. One of the ways in which I think we can integrate some of this thinking around why unfair health tends to accumulate, why poor healthcare outcomes tend to accumulate unfairly is by integrating history and theory. With respect to tribal communities, on the right side of the screen, for example, if you Google this title, you can get this article that we wrote in Down to Earth magazine along with a collaborator from Theta Project, Madhu and Pavitra. In this article, we try to examine the very contested relationship of Adivasi communities with tiger conservation. And this is very strange as to why this debate needs to belong within a conversation about their health. I mean, it might appear strange, but the history and implementation of wildlife conservation policies has universally and globally had a very adverse impact, an unfair impact on tribal communities. And let me explain why. We are talking about communities who have perhaps the lowest ecological footprint among all of the global communities. Yeah, in terms of, for example, use of AC, use of SUVs, in terms of use of any of the high impact climate change drivers that many of us are used to and we take for granted in cities, are not used invariably by many people living in and around forests. However, they are denied roads, electricity, water supply, and many other basic amenities because they are choosing to live where they live, and because they have chosen to conserve wildlife, unlike other places where wildlife has anyway gone away. For example, even on the outskirts of Bangalore, during colonial times, not very much in the distant past, white people have hunted tigers. Yeah, so there were tigers right outside Bangalore. Now, people and communities around Bangalore and the urbanization that happened removed, extirpated tigers and various other species of high biodiversity significance from these cities. That is the only reason we are not having a tiger reserve in Bangalore. Imagine if someone comes tomorrow and says, look, we are going to conserve North Bangalore and convert it into a tiger reserve. The backlash, you would imagine, is enormous. But then if you ask the question, how come many Adivasi communities have been able to bear the brunt and have not complained about the fact that their freedoms get limited by wildlife conservation policies? When you think in this direction, you realize that these macro policy drivers also limit freedoms, they limit liberties, and they create an unfair accumulation of disadvantage in many of these communities. And to a large extent, this is true with Adivasi communities, because if you see the Nilgiri region in southern Karnataka, Tamil Nadu, Kerala, Tri-Junction, or you take the central Indian Chota Nagpur Plateau and that whole belt, Chhattisgarh, Jharkhand, bordering Madhya Pradesh, and if you take many states in Northeast India, these are states where there's still a large amount of forest left, and there are many communities who have been living for centuries, if not more, depending on completely with their livelihoods, etc., depending on this forest. So by bringing this kind of historical the idea of entanglement between tigers and forests and tribal communities, and theory, the idea of historical disadvantage, the idea of colonial and post-colonial policies and how they have not mitigated the disadvantage before, we begin to become aware that the current status of what we say, illiteracy or lack of knowledge, or they are not utilizing health services, we begin to see these in new light. So the individual variables we collect in our surveys acquire a different meaning when they are located within this wider theoretical and historical realities. And that is the point we make in our in the article I have screenshotted on the left, along with several other colleagues, on need to expand our understanding in public health of behavior not often being a free individual choice that happens at the instance when healthcare or health services are being delivered. What did we do in the project? We tried to approach Adivasi health, tribal health from a multidisciplinary perspective. Of course, everyone says we are multidisciplinary. So let me explain how we approached it. So on the right side is the framework of different types of questions we can think about in this emerging discipline called health policy and systems research. Health policy and systems research, without going into a great detail, is a problem-based discipline. It's an academic inquiry that is centered around real-world problems. So in that sense, you can think of descriptive questions, questions that determine influence, like between quantitative variables, but you can also think of emancipatory questions, questions which involve methods which leverage participatory action research. You can think of explanatory questions, questions that push researchers to theorize, to create context adapted, or the theories that are that can explain why things are the way they are in some contexts. You can think of exploratory and predictive questions. So some of it is from this reader that I had an opportunity to contribute to. And broadly, these are the kind of questions that we approached tribal health with in this project. So what did we do? We started asking, okay, what are the patterns? What are the patterns of inequalities with respect to tribal health? But what are the processes through which we begin to see these patterns? And finally, what kind of action could actually mitigate or alter the processes which are driving some of these inequalities? Patterns are typically a quantitative, of course, I mean, arguably, patterns we conceptualized in the project as a quantitative enterprise. So where we try to characterize at a very fine scale the healthcare and health differentials between tribal communities living in multiple forested sites in southern, central, and northeast India, when compared to non-tribal communities who are living in the same region. So this is very important, because if you see NFHS 5, the National Family Health Survey, which is one of the several demographic health surveys that that are conducted in a globally standardized pattern across the several countries. If you see NFHS 5 for the first time, I think, gives district level data. So if you go deeper and ask, how does NFHS 5 give data generalizable to the district, you will see that they would have used a sampling pattern that allows one to generalize healthcare indicators to a given district. But if you look at which are the communities which they categorize as ST, you will see that for various reasons that I won't go into this presentation, there are many urban and peri-urban communities which have relatively lesser social and historical disadvantage, which are also categorized as ST. So many of the data from NFHS 5, which have to do with ST, do not adequately represent forest dwelling and forest associated remote Adivasi and tribal communities. So in our survey, we approached it from the opposite end. We said, let's start with forests. Let's start with these 5 different tiger reserves in different parts of the country, and try to understand what are the kind of patterns of inequality between tribal and non-tribal communities who are both living in the same geographic location. The second objective was more on theorizing using social science work, and the third was participatory action research. I'll unpack these 3, and I'm aware now I'm already taking more time than I wish to. But anyway, so this was the protocol that is there on the right side, which is available from Welcome Open Research. And like I already explained, the idea was to really look at fine scale whether inequalities that are reported in NFHS and elsewhere, do they hold? Why is this important practically? It's not only of academic significance, because sometimes when invariably when public health professionals are asked, like me, how do we act on tribal health? Invariably, the solutions emerge which are related to geographical distance, right? So somehow in our stereotype of tribal communities, it's the distance from the city that seems to be problematized, rather than let's say, for example, the social identity or their neighborhoods. Yeah. So one of the reasons for choosing to take up this hypothesis is to try and understand, is it true that when Adivasi communities, for conservation reasons or for various other relocation reasons, move closer to villages and towns and cities, does it really have a positive impact on their health? And we suspect not. And some of the patterns I will report today, but the main analysis of whether the disadvantage with respect to some of the Adivasi communities is socially constructed or is it largely geographically or locationally constructed will become more evident as we unpack that analysis. A lot of the work happened from our field station, which you see here in the South Indian study site in Biligiri Rangana Temple Tiger Reserve in southern Karnataka, Chamarajanagar district, at the tri-junction of three states. The other sites are around Kanha in Madhya Pradesh and around Pakke Tiger Reserve in Arunachal Pradesh. We also had a field site in northern Kerala in Wayanad. And obviously, to do this kind of work, there's a lot of people who have taken responsibility within each site to lead and to build local relationships and to create, at least in three sites, in Kerala, in Karnataka, and in Arunachal, a long-term engagement with communities that we worked rather than having a parachute data in and data out, which we also did, for example, in Madhya Pradesh, where we did not establish a long-term field station. Just to give you a flavor of some of these locations, this one is, for example, the Soliga community's hamlet village in Kadakalakindi in BRT Tiger Reserve at a fairly high altitude, surrounded by what is called a Shola habitats, grassland Shola complex. This one is Gajagadi, a Katnaika village in Wayanad, where my colleague Sabu was leading the field site and data collection. Baijalpur in Madhya Pradesh, a Gond village, and Nere Nishi village in Arunachal, some of the field sites where we did the collection. I won't go into great details on the fact that we used an app, etc. Like Shirley was mentioning in the introduction, one of the technology seems to be the easiest peg in the jigsaw puzzle of how to work, how to advance our understanding of tribal health. And we used fairly standardized, good quality cloud-based technology to be able to collect good quality data with local language adaptation, and of course, a bunch of people from local communities. For example, here is Julie, who joined our project as a research assistant and is recently got a PhD of her own and is now pursuing a PhD. Julie is from Eastern Arunachal Pradesh. We use the same variables as the DHS, NFHS in order to preserve comparability. And see here, for example, the point I was making earlier, you have these red dots within these green borders, which are all the tiger reserves. There are two tiger reserves here. One is the BRT Tiger Reserve, and on the right side is MM Hills Wildlife Sanctuary, which has been notified as a tiger reserve recently, but being heavily protested against by the Soliga people, who gathered in thousands recently to register their protest against declaring MM Hills as a tiger reserve, while a lot of their rights remain still pending for all these settlements that you see in their sanctuary. And really, these various settlements were all the places where we collected all this data. And to very quickly summarize, I think we covered a total of 217 villages, which are spread, which consisting of 1,288 tribal respondents and 1,072 non-tribal respondents, households, and with various other characteristics. In some of the places we also collected, especially in southern Karnataka, we also collected biomedical details. This was primarily on dyslipidemia and hyperglycemia to characterize dyslipidemia and diabetes among tribal communities, given that many of them are going through their own epidemic of cardiovascular disease, stroke especially, and hypertension. I won't go into great detail of some of the preliminary results on the quantitative data because I do not have the time. But a lot of the data that's coming out is able to give us a more nuanced view of inequalities and differentials across states. For example, is the inter-tribe inequalities in Kerala very same as those in Karnataka, or is being an Adivasi in Kerala very different in terms of attainment of healthcare and health status from Arunachal or Madhya Pradesh? So these are the kind of nuances we wish to advance, because to break this stereotype of one tribal India, which is not the case, and more and more we converse with many different Adivasi and tribal communities, the more we realize that there is a problem in the way tribal health as a discipline or tribal health as a phrase has been understood by us, like me. I'm not myself from an Adivasi or a tribal community, but work closely with them. So the way we tend to conceptualize, problematize has also been a big problem, and we hope to change that. A tangential thing we did in between was to identify hotspots of malnutrition, and using NFHS data, and we try to look at households and individuals and pockets where different types of malnutrition co-occur, especially co-occurrence of 3 different types of malnutrition, what is called as a comprehensive index of anthropometric failure, which we characterized and identified these 4 hotspots. And even there, the category related to ST had significant disadvantage. And a very recent paper in BMJ Global Health, based on the previous one, where we show, especially, for example, tribal communities in Gujarat, particularly, where so many districts are reporting high incidence of wasting and severe acute malnutrition among tribal communities. This one is analysis from a very recent paper we published in BMG Global Health, titled Alarming Increase of Severe Acute Malnutrition in India, based on the latest NFHS data. So back to the survey, we also characterize dyslipidemia and NCD risk factors, and in southern Karnataka, we also are going to be able to report on the geospatial epidemiology of sickle cell disease among Soliga and Jenukuruba communities. Sickle cell disease is one of the neglected tropical diseases, and it's one of the reasons for its neglect vis-a-vis, for example, hemophilia, is also because of the fact that it is mainly reported in remote, rural, and Adivasi communities who have not been able to advocate for their mitigation of their health problems substantially enough. So that was the quantities, and a lot of it is still going to, I think, be reported in the coming months, especially the idea of social construction of disadvantage. Now, coming to the theorizing component, I think the predominant question here was why and how are systems, not only services, failing tribal health? And if you look at the enormous amount of work that has happened, and we must acknowledge inspiring work that has happened by several non-governmental organizations in different parts of India, where typically doctors, but also others, have gone and figured out more participatory ways of engaging with tribal and Adivasi communities, and have created wonderful islands of excellence where one can still go today to understand how perhaps one could participatorily create community programs. But the question is not so much about creating islands of excellence. The question is really how can we hold systems accountable? How can we ensure systems perform? And how can systems be more responsive to tribal communities? And there, like I said earlier, there's a very, the elephant in the room, so to speak, when we talk of tribal health, is actually livelihoods and forest rights. To a large extent, many of the tribal settlements in central India and southern India that we work with are unable to secure basic amenities because they do not have rights over their own ancestral lands. Now, to go into the historical and political context of forest rights and tribal communities in India will require a separate presentation, but there's a lot of material, and especially many environmental activists, many conservationists, and many tribal activists themselves have written enormously on the very contested nature of this relationship, which prevents roads, which prevents water, which prevents electricity, which prevents amenities from reaching tribal areas. And for that purpose, in 2006, Forest Rights Act was passed, and unfortunately and sadly, the Forest Rights Act, which seeks to mitigate some of the historical injustice meted out to Adivasi communities, has not been uniformly implemented. If you take, for example, the case of Chamarajnagar, where the Soliga community has taken huge amount of leadership in securing their rights, this is some of their successes has also been exceptional. It's not been the case with several other communities, for example, the Jainapurba communities in neighboring districts. So this is a continuing struggle which falls outside the ambit of health, and we need to be able to find meaningful research methods and meaningful ways of articulating our question, so that some of these which have a strong bearing on health are also included into our solutions. Because otherwise, we are always going to imagine that problems with tribal health has to do with distance, and we'll continue investing in mobile health units, which is really a failure, I would say. I'm very biased against mobile units because I've seen them as being band-aid solutions where you equip, you have a jeep and you have some essential medicines, and someone goes to distant and remote tribal areas and dispenses basic medicines. Now that doesn't really impact health status substantially enough, providing these charitable medicines episodically in remote and rural areas. So, and there are various other things, some communities, like for example the Koraga, who are a particularly vulnerable tribal group in Karnataka, report decades of discriminatory practices, some of which probably continues not in the same obvious way, but has had its own form. So when you go from one tribal identity to another, we begin to realize that the relationship between them and the state and them and each other also conditions a very particular experience of the health system. So, so that's the reason we wanted to, in our objective, to shift the non-tribal academic gaze, which tends to locate the problem of poor tribal health within individuals and does not sufficiently problematize the policies and the systems which are the reasons why individuals appear to have poor health. And I think I've already sufficiently explained this. So one of the publications that came out of this is to try and do an interpretive synthesis of the health of indigenous populations in South Asia, which with some of our collaborators we published in the International Journal of Health Services. And we propose a very minor change in, minor change. Rather, we conceptualize, especially in the last column on the leftmost in this framework, the social welfare policies and affirmative action and forest regulations and conservation priorities, which seem to be having an important effect on their socioeconomic position, which in turn determines their material circumstances. And all of you will recognize that the figure on the left is an adaptation of the social determinants of health framework. So which is where a lot of underlying reasons for poor tribal health is located. One of my PhD students, Anika, is also continuing some of the work on theorizing, and she is looking at built environment and neighborhood level disadvantage. How do Adivasi neighborhoods aggregate disadvantage? Why don't they attract development? Because the way we problematize sometimes helps shift the focus of the solutions. If we ask, why are people not developed, is one way of framing something. Another way of framing something is, why did development not reach this neighborhood? And the latter framing is, I think, extremely important in public health, because the latter framing draws upon theory and history, whereas the former framing tends to problematize individuals. And we know from enormous work by activists and social science work that individuals rarely have the power to shape and change the forces that are affecting their health. And the case in point, for example, is there on the commercial determinants of health, where, for example, transnational corporations are able to determine what food is on my plate, and we can all imagine that these are all me as an individual making a free choice in the market and deciding what I shall eat. And a lot of work in commercial determinants shows us Similarly, we try to push more an understanding of the system within which tribal health gets created in the second objective. Another PhD student of mine, Meena, along with our collaborator Madhevamma, who is from Yerkangadde, one of the settlements here, together have been trying to understand healthcare experience and patient rights. What does it mean? What does it? How do Adivasi patients understand, conceptualize, and articulate their rights? And how does their healthcare experience in free care? No, I mean, under Ayushman Bharat, several procedures are covered. Many things are free. There is also an Arogya Mitra who is supposed to facilitate care in hospitals. But the reality is very different. Healthcare experience is not smooth, and far from it, it's very, very adverse, and it needs many, many people to navigate the patients through our complicated health systems and our complicated systems of claiming benefits from these programs. So we are continuing to advance and see how cultural safety frameworks, how healthcare experience frameworks could help us better inform how to improve access, as opposed to telling people that they have to access care early, because that's usually the focus, that education and knowledge creates change versus welcoming services which actually create change. So in the last bit, maybe I take, Shirley, I'll try to wrap up in about 5-10 minutes, the last bit on action, so that we have some time to exchange. The action component used participatory action research, and it's very difficult to report results of participatory action research. So what I'll do is the two arms of participatory action research is action and reflection. So the reflection component is represented in these three papers, where we try to understand the nature of collaborative or participatory space that we have created in southern Karnataka. So this work in objective 3, we did not do it everywhere because of the very intensive nature of the work. We restricted to Chamarajanagar district, where we have a long-term alliance with the Jilla Budakattu Girijana Abhivrudhi Sangha, which is a collective, a district level collective, a federated collective of Soliga Adivasi people. They are very well organized, and we partnered with them. And in the reflection component of PAR, we try to understand the nature of the collaborative space that we have created. So who has a voice, who gets invited and who doesn't, and what is the way in which questions, who gets to frame questions in the participatory space? What about access or power to influence decisions? Who has those? So some of these aspects we try to unpack through one case study, and from that case study we were able to explore 3 different themes which are there in titles of these papers, which are all openly available. In some sense, we look at this as a contribution to the practice of PAR. That's one of the things. But in terms of action, like I had shared in a brief that I had given to Noora Health about this talk, meaningfully changing tribal health cannot happen through a well-designed program, because there is a long history to there's a long history to who is able to influence the neighborhood and policy context of tribal communities, and there is a need for quite some institutional change in order for people to be able to even realize their rights and to be able to access services meaningfully. So to some extent we try to intervene at different levels in this axis that goes from social institutions and structures right up to which is individual. So we conceptualize this as the transformative action element, because the project was called TITA, Transformative Action on Tribal Health. What did we do at the individual and neighborhood level? We had a program theory on the right, which I'll not go into great detail. Some of this is still being written up. The idea was, how do we create inclusive spaces for young Adivasi youth to collectivize? Because one of the theorizing components was telling us about the diminishing social cohesion among many Adivasi communities for various reasons, because we also live in a world where which is highly competitive. So we seem to be building a world where we would like individuals to be in competition with each other rather than a world where we can all work together. So under this myth of, oh, resources are limited, so everyone has to compete, and the best one gets a good job, best one gets a good seat, and things like that, which is something I will return back later. So we said we tried to create these participatory spaces in the form of 14 sports clubs. And the reason for these sports clubs was because from the Theta survey, the pattern of alcohol and tobacco use among young Adivasi people seemed to be very different from the pattern of tobacco and alcohol use in various other communities. They were young, they were taking it on at a much younger age. There was more instances of harmful use, and there was hardly any access to cessation services, counseling, etc. And we live in a world where we would like to immediately brush off any dependence on traditional systems as superstition. So on one hand, diminishing traditional systems, and on the other hand, modern medicine has not caught up and provided enough cessation services and things. So this was the wider social context within which we tried the sports club intervention, and I'm very happy to share that this really went beautifully. We had several volleyball competitions. To cut a long story short, we chose volleyball together when we sat in these groups, and volleyball worked well to bring youths together. And today we are scaling this up with collaboration from several others. We are trying to convert these into ultimate frisbee clubs, which will also have a more structured curriculum on self-management, self-care, and various other psychosocial aspects, which will be introduced through group discussions. We also had ongoing discussions with various taluka hospitals and local hospitals to try and improve the healthcare navigation, and to try and have tobacco cessation services established within some of these places in a way that makes cessation accessible to the communities. And we advocated for placing Adivasi social workers within secondary and tertiary care hospitals, so that people receiving tribal patients are also from the Adivasi community and are able to provide a bit of cultural safety, where people who are going from a faraway forest to a city-based hospital feel safe, that there is someone they know. Because we must, social networks of many tribal communities end as you go further away from the forest. And we know from our own patterns of healthcare seeking among the more privileged that social networks are very important in feeling safe or feeling safe with a healthcare provider. So this was a kind of an attempt at trying to replicate that logic. Some of the work continues through an ICMR grant to my colleague Yogish, who is working with few primary health centers to try and improve access to non-communicable disease care in these centers through a grant. And we got these two wonderful colleagues, Sushila from the Koraga community and Madesh from the Solika community, who were our liaisons with these two community-based organizations. And they took leadership in the policy engagement, and they were able to secure substantial achievements in advocating for things like setting up of a tribal health research cell in medical colleges, for which guidelines are now being written, and various other recommendations to create support systems in large hospitals for caregivers, tribal caregivers who go there, so that they can get some food and shelter when they go to these big city hospitals. So this is work in progress. They have been able to secure government funding, and government has committed to do some of this, and we hope that in the coming months and years these will actually be implemented. But a substantial piece of the PAR work was led by C. Madegowda, who is from the Jilla Budakattu Girijana Abhivruddhi Sangha. Madegowda is a researcher in his own right, and has been working on forest rights for well before we came into this context. And through our project, we were able to try and understand more the relationships between forest rights committees at individual hamlet level and health of these communities. So 105 hamlets held these forest rights committee meetings, where we discussed connections between health and forest rights. I'll skip a few slides, and because I'm already at 6:15. These are some of the other outputs in terms of HPSR field building, and I won't go into detail on these, nor will I. I'm just sharing very quickly that we also used some of these insights in shaping things like One Health, which are severely biomedical with limited social science engagement. So some of us have been able to try and also share some of these insights into ongoing One Health research work on zoonotic diseases, where the experience of social inequalities of tribal communities is an insight in shaping how that discipline moves. So this was the paper I was alluding to on the a message that I share with people like me. People maybe a message for, let's say, people in positions of one or other kinds of privilege who continue to dispute sometimes the reason for affirmative action. And the problem here is that I feel that a lot of the reason what we see as social disadvantage is often happening through historical processes of exclusion, and without actually ensuring that we acknowledge these historical social inequalities, it will become extremely difficult to design meaningful solutions. So some of this I try to explore through a very personal kind of reflective editorial by this title, which came last year in BMJ Global Health. And we, of course, had a lot of outputs in terms of people who are on various research and other tracks, and of course collaborations, etc. So currently, I'm speaking to you from a field station where we are now setting up, consolidating some of this work into what we are calling as a Center for Training, Research and Innovation in Tribal Health. It just started last year, October, and we take some of these learnings in trying to continue participatory design of interventions, but also trying to set up action on early childhood development and on hemoglobinopathies. I think I will end, sorry, one more slide, which is this collective. It's available at this website. So one of the things I found is that a lot of scholarship on Adivasi health is in the oral tradition. A lot of it is not in peer-reviewed format. So over the next few years, we hope to build this kind. Currently, this is an online archive of Adivasi scholarship centered on southern India. But over time, I hope to perhaps one day also have a physical archive of oral knowledge and traditions of various indigenous people. But that's still an aspiration and ambition. Perhaps it will, perhaps it may not. Thank you. I think I'll stop here so that we can have some interaction. Sorry for taking much longer than I foresaw. And I list several people who have been important in shaping this work. Over to you, Shirley.
Thanks so much. And please, not at all. It was really helpful to see all the different ways in which your work has spanned across. So thank you so much. If folks have questions, you're more than welcome to come off mute or put them in the chat as well. I'm just going to start off with a question from Ritika, where they ask, could you tell us which non-forest dwelling urban communities are included in the ST and the NFHS?
Yeah, so I don't know the history of each state, but if you look at most states in India, there are multiple communities that are included in the state list. So the notification for a scheduled tribe as per the procedure is a state level initiative. So states have established their own process where they take into consideration various statutory norms and then recommend for inclusion of a specific community into the list of scheduled tribe. If you look at Karnataka, for example, the 12 or 13 forest associated Adivasi communities are about 15 to 20% of the total ST population in the state. So if you look at the 80% of the ST population belong to one community, Not all of them are urban dwelling, but this community is largely peri-urban and rural. And I think it's not useful to problematize the community itself. Here, I think what is very important is how do we ensure that the benefit of being included in scheduled tribe is uniformly available to all communities included in scheduled tribe. So I won't sort of go into naming specific communities which are urban, etc. And by the way, urban dwelling ST, like our work shows, also have a huge disadvantage. So it's not that it's some urban dwelling that actually quite advantage. More and more work from intersectionality world tells us that we must locate a disadvantage not only at these broad social categories, but at the interface of individual, neighborhood, and various other identities. So I hope that answers your question.
Awesome,
I see another question from Pawan. Shirley, shall I take this one?
Please go ahead.
Yeah, home care services in tribal hamlets. So this is a very good question, and I think it's very interesting, this question, because in one of our discussions, somebody was asking, how do you deal with the tensions between the need for biodiversity conservation on one hand, which is also very important. Tigers are important. Tropical forests are important in terms of global climate change. But on the other hand, we cannot be achieving that at the cost of denying human rights to a bunch of people who are living there, right? So immediately the solution is to create high standard amenities in remote and rural areas, which all will also have ecological impact. So I think one of the ways of resolving this tension is in fact this kind of home care services, but it will have to be reconceptualized in Adivasi areas. It will need participatory and consultative discussions with people here. It will need rapport building and community engagement. What will not work is to copy paste something that is working elsewhere and to try and replicate that by training local women and say, okay, now you will provide home care services like we do it in Mandya or like we do it in Bangalore or in Delhi. That won't work. So it needs some kind of co-creation, and I think those kind of work, I'm not very sure if it's happening. Yeah.
Thanks for your question, Pavan. Anyone else have any questions they would like to ask or comments too? Go ahead, Ritika.
Access to tobacco. Access to tobacco is again, we in line with what I was saying. I think we'll have to reconceptualize access also. I'll take the example of alcohol. Alcohol, for example, and we can come to tobacco. Alcohol, for example, has also been something that has been used by landlords to seek cheap labor. So if I hire daily wage workers in my coffee estate, it has been a practice to give alcohol, right? Why? One, people feel nice that I am being benevolent. I'm not only giving a daily wage, but I'm also giving alcohol. I get habituated, so I know that if I work in this guy's estate, I get alcohol. So sometimes access is also not an individual choice. Many communities have become addicted to alcohol through facilitated access from landlords, feudal relationships, other relationships which try to introduce and push and benefit from people becoming alcohol dependent. Tobacco is, of course, a different story. Tobacco, I mean, tobacco has, I started working in this area in 2003, immediately after my medicine. I was a doctor at the time. And already in very remote areas, tobacco was available. I don't know how tobacco makes it. In very remote areas of Arunachal, for example, where vaccination rates were still very poor, I could see scripture, religious scripture in local language that was available. So I think the explanation lies at the interface between people and their seeking of recreational substances and macroeconomic interests of being able to creating a supply chain that reaches the last village. This will need a lot of work, and one of our colleagues, Arun, has recently joined CTRIT project, where he will be doing some ethnographic work on trying to understand the relationship between tobacco, specifically with communities here. I hope that answers your question, Chetna. And thank you for Seema's compliment on the number of publication. I think that happened because of the number of people that took leadership in shaping different pieces of work in their own way. So that's the secret, I think. I'm just going to take a minute, Shirley, to read I'm sorry, Akash Solanki's question.
Sure.
Yeah, individual behavioral change to improve health outcomes in international development. Yes, 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 yes. Yeah. Individual is always quick wins, frankly. So I don't know. It's a losing struggle, I would say. And it's also a losing struggle because we are increasingly in a macroeconomic framework that celebrates individual success as if the individual success is shorn of any social creation. I mean, I'm a fan of TED, but look at the TED format. And just for sake of critique, I take TED. It could be the Wellcome Trust Fellowship, for example, that I secured 5 years back. It could be anything. So we somehow have located our wish for change as probably coming from a smart individual idea. So somehow we feel that many smart individuals, you put them in a room and then they will crack the problem. And I think this is at the heart of the wider economic world we also live in. So individual merit tends to gain a lot more primacy in recognition than collective success stories. Collective success stories somehow are slow and they are problematic. If you see also the way we go about problematizing social activism itself in the wider political milieu, I think this is a very huge problem. We really need to figure out a way of having a dialogue where we can encourage much more collective action and collectives as opposed to individuals. And I frankly don't know how to go about sensitizing this. Also because projects, international development you mentioned, international development is a big problem. It's a big corrupting influence, I would say, because these tend to look at projects. And we have forgotten, I think, that a lot of change, take for example, what this current work sits on. It sits on decades of work of the Jilla Budakattu Girijana Abhivruddhi Sangha and the Vivekananda Girijana Kalyana Kendra, who have been working here for some 30 years, building a federated collective of Soliga Adivasi people. It's because all of that was available that researchers like myself am able to try and amplify and leverage that decades of work. So I wish I had a more convincing bullet point answer as to how you could do this. But maybe more of us need to talk about it, and more of us sometimes in the room when somebody cheers an app that will change the world, maybe some of us should stand up and say, hey, wait a minute, this app may be brilliantly designed by Stanford, Harvard, IIT, and IISc, but I think an app will not cut it for many communities we work with. So somewhere I think we need to step up and speak boldly, even if it means that we won't be cheered. I think somehow that's something that comes to mind. Sorry. Shirley, shall I take the next question? How do you propose?
Yeah, sure. I think we have 2 minutes left. So how about this? There's 2 other questions. I'll just read them both and you can figure out the best way that you want to respond to both. So Akash had a second question. How to bring the land question back into policy and public discourse. Land redistribution is an original solution that upper caste elites dropped midway. The social determinants of social services have been lost in the category of quote unquote poor minus social background. How do we force social back into social policy debates? You seem to have succeeded. Please share more of how please show how more of us can replicate your success in other contexts like Chhattisgarh, Jharkhand, and other states in the country. And then Ritika has 2 questions as well. First is there are over 40 communities identified as ST in Karnataka. What kind of nuance is the NFHS classification missing when you talked about the need for a finer scale to distinguish between urban and forest dwelling ST communities? And then do you think that the absence of PESA, the PESA Act coverage in Karnataka is one of the factors of disempowering the communities to move the state with regards to demand of welfare actions, including healthcare for the state? Yeah, so a lot of, yeah, do your best.
Each and so, I mean, these are very complex questions and they deserve a long discussion. And some of these questions, frankly, need a discussion with many of my Adivasi colleagues rather than myself. But let me share my insight based on what I gained from the discussions with them. I think this is very important, Akash Solanki's second question on this idea of poor. It's so bizarre, and we often talk in these conferences and workshops like poor is one category, right? And rural, for example. Some of these are very problematic stereotypes that all of us have very different conceptualizations of these in our minds, and we often, I think, make solutions that reflect our own ignorance of the diversity in these large categories. And so I really don't know. I think a lot more social science work needs to happen within health, and we need to really bring that. That's one. But we also need more public debates on this. But we need more public debates with scholars and individuals from Adivasi communities, like, for example, Seema Degoda, who's got enormous experience in how he was able to bring about this kind of collectivization in Chamarajanagar district. But to address your second question, it's very difficult when I sit and discuss with many of the colleagues about the idea of scaling up and replication. They say this is extremely difficult. What worked here, I don't know whether research, scaling up, and all of these are good enough frameworks to be able to do that. The only thing I think what could work is greater exchange between different tribal communities themselves, and whatever the non-tribal privilege can do is to facilitate greater exchange, sharing, greater emergence of leadership within their communities, rather than go and implement solutions that we think could work. That's broadly a kind of a summary that I can share given the lack of time, but we can pick this up. I don't know how, but yeah, this is going to be an ongoing. Ritika's question is, see, 40 communities you say are STs, of which I am aware of 12 to 13 which are forest associated Adivasi. Many of the communities which are named as ST are, some of whom are untraceable, I would say. They have been included historically in the list. If you look at NFHS data, there's only one. You're asking what is the nuance missing. There's only one ST. There is no Soliga, there is no Jainkuruba, there's no Koraga, there's no Yarava. There's none of these identifiers. And these are all very different communities which have their own social identities, histories. They have very diverse political engagement, very diverse relationships with the state. So how do you even bunch all of them into Karnataka ST? For example, is being an urban ST in Bidar same as being a remote rural ST in southern tip of Karnataka? I will give it to you that their worlds are very different. Even the ecology and habitat of their environment is different. Their social history and environment is different. We do not have that data. In fact, the expert group on tribal health headed by Dr. Abhay Bang from Search Gadchiroli and various other tribal scholars pushed for need for better data, but that's still not materialized. So what we get from NFHS is ST, a broad brush. Beware that ST of Karnataka, ST of Arunachal, ST of Kerala are all equalized in the NFHS data. It's the same. And second question is really one of the, I mean, you have framed it as a question, but I think it's a very important reason why I think things are not going well. We do not have PESA Act coverage in Karnataka, and definitely this is a huge disempowering trait, which makes tribal communities in Karnataka different from, example, communities in central India, where PESA is much better available and implemented. I'll pause here, Shirley.
Thank you so much for your time and sharing just a wealth of experience and knowledge with all of us. It was really wonderful.